This is Blending checking in.
Hey, Mindy.
Hi, Wes. For a minute.
Dragging today. I don't know.
That moon.
Moon.
Yes, all right.
That's what I heard too. So
What's it doing?
There was an eclipse. It's full, and there was an eclipse yesterday. Lunar eclipse. Really big last night.
Sluggish. It's like just, I don't know. I woke up that way. I went to the gym. I still feel sluggish. And caffeine doesn't really wake me up. It just makes me pee. So, you know, it's like it doesn't do any good.
It's anymore. It's like
It's just,
Something that works, right?
I know.
It's not there.
it's not exciting in your world, Miss Gina. Same old stuff. What are you doing?
I'm surprised it's still warm. It's nice.
I did.
I don't.
They're not sure if you want to be
Together. But yeah.
You know, sometimes you're just like, it's too exhausting.
Alarm went off and I was like,
Sometimes it doesn't work here. Sometimes if you sleep almost too long, you're dragging more in the morning time.
still
Sleeping well?
I
Oh,
had a number of days where so there was a big
See if that's really out there.
off.
Not the one time with Lorraine, when she was doing it to do it, you know, a little flip for her staff out there. I'm like, this is a nice building.
meeting to accomplish.
I know.
Did you guys see an Airbnb or did you? Yeah, was it nice? It was alright. Oh no,
But it was
it's affordable.
It's tough. I gotta tell you, I
it
like
was still coming
just because it's really quick. I'm like, I go to sports now, so it's quick to get to work. But even when I was just doing Vasa, I would do 15, 20 feet to get off, and then just loop on over. It wasn't bad. 44, which was
Because even when we had ours, it's not on the beaten track.
I went down to camp and just
it was sweet Saturday.
his wife Jessica. It's the only place you could find something nice that was affordable. All the stuff was
I think, yeah, I think that you want to be down there.
Okay. This is 150.
where they max out.
I know what the crackpot was cost.
Which is disgusting. That's a stretch.
That's how another person was in here when I first arrived.
Well, you can keep me on the list.
Pictures of Times Square really dark.
Related.
It is.
And it's one of the ones.
How many crimes are committed? Yes, you don't know alarm systems, nothing.
That's right.
You know that clock says it's 10 to 6?
I know, isn't that irritating?
I was just looking at it and I was like,
You expect everything in this place to be shipshape.
clock says it's 10 to 6.
Oh, that's why I feel so tired.
It doesn't say, it doesn't indicate AM or PM, but
Please do. So, not only see the baby.
But it's Comic-Con.
Oh, God.
But,
Streets.
I had to look at them all. $4. Maybe vacation time.
Super excited about the people watching and then it was
Honestly, that is one of my talents, is names.
that's good.
I am really good with names.
Oh, I had to take a mental health day yesterday. Yeah.
I've known her for 30 years.
No.
Like right when you go,
What's going on? All right. You try to get
this person right here.
cleaning the house. Oh, the clean and
Yeah.
I could tell you their little
Yeah.
Clean this toilet so
See, in that part, I would struggle with a little bit.
Hello.
Good morning, Missy.
oh, I know what I call it. I did a little chatter.
No, I feel the drought.
No, what I had before.
This is just not on my agenda.
Good morning.
No.
Plan for this today.
I don't know what she's drinking, but it looks good, doesn't it?
Starbucks, too. Have to.
Oh, the pink drink. Yeah.
We are going outside in California.
It's like coconut milk and strawberry.
So I brought that for
My daughter has me hooked on those drinks from
it's its birthday.
Spritz Skag. What's it
Going for a
called?
whole week and we're going to go
Dirty soda.
start.
I guess, yeah. And it's the one particular place that's not far from my home.
Uh-huh.
And my favorite one is
We're going to go to Monterey.
Diet Sprite with pineapple.
We're just doing one night there.
I don't know why I ordered diet with all the other goods,
I know.
but you know. And then the touch, whatever it is, I put in. It's like pineapple and cherry and lime and something else, and then cream. Oh my gosh! It looks similar to this one.
Sounds luxurious.
We've got
Jan, how far away are you from retirement? Too
Well,
far?
it depends on what day you talk to me.
Yeah.
And what hour.
Yeah, truly.
Some days I go, I'm gonna do it. I set this mark. I'm gonna do it. And then others think, no, but
How's your summer
go a
been?
little further.
Yeah.
I know, that's how they entice you. It's how they get you to stay.
I know. Well, you go a little.
This is blinding. We can't seem to hear you.
No, we say,
Yeah, I saw.
just do the best you can at the moment, because in 6 months, someone's gonna blow a whistle and we're all gonna switch again.
You slowed down a little bit, but
I know when you make sure there's one that is an
usually you see a pretty big drop. Hours away,
but I've seen where you're living, so.
I looked at some of my stuff from March, and we were on
like
looking at it, and I
it
said,
has slowly been going down, but like not
anything
like
I
that
did in March
drastic
is not the same as what I did today.
as we've seen.
Same as what I did today. But I think
It's very interesting.
it was like studying for finals every day.
Same-ish sort of stuff.
That's exactly how I felt.
See, and we're so
Everyone's doing good, right?
As far as it's like the care plans. Well, a lot of that was coming from
Daughter's car broke down.
So then that's why, because we have that thing, yeah.
It's
The regulatory requirements for care plans are absolutely ludicrous.
So expensive.
Everything's based on the cost, yeah, but that's right, that's exactly right.
most cares.
So we haven't seen like a big enough drop.
They do, they have to do surveys for the,
I will.
Yeah. I see.
Oh, your fax.
yes, very similar, but in order to meet, it's different than press money, but in order to meet the regulatory requirement. And we scored really, and I said, you're not including the pediatrics. You're expecting the parent of a child to answer regarding themselves, not the child. So finally, last year, they redid and did a pediatric survey, and finally, Linda, who's in charge of it, came to me and she said, you were right. Scores jumped up. Duh!
Yeah, duh. I know. Oh, but the thing, I'm so bad.
You come very far.
Just speak up. Am I changing? You're changing.
You kind of have to be that way.
We'll go with that.
That's what I told it when I
You have to
It is one of my roles as a nurse.
changing.
Back in the day, you're like nursing school.
Oh, you're I hope the Catholics just kill me. I don't know. They think, they meaning
She live out there.
the agency that drives the nursing process. I don't. We're not allowed to do it in iCentra, but I can read the chapters. We have a system called Care Radius.
Yes, she's still. Okay.
For insurance. Yeah.
Just beating me to death with personnel.
It's got to be better than what it's called.
Oh, I don't think it is.
Yeah. See, and I don't dare say a word because Michelle. She's now the new. She's the new. So, like, what you call it? Sisters.
Good morning, everyone. I think we'll get started, even though we've got a couple people still signing in and sitting down. Don't worry, just keep doing it. Let's go ahead and get started. Good morning. This is a nice turnout. We weren't necessarily expecting quite so many, given that it's summer and people are on vacation and all of that, so this is terrific. So yeah, let's go ahead and our agenda is today. So we'll start out with some introductions, like we always do, and just a few little housekeeping things. We will then go on to our usual brainstorming part, and that's the opportunity for you guys to talk with your peers about anything that's going on with your cases, any sort of wins you've had, any resources you've come across that you'd like to share, those kinds of things. And And the bulk of the meeting will be a presentation by Lana Stohl, who is the Deputy Director for the Department of Human Services and the Director of Utah's System of Care. So we're very excited to learn more about the system of care and really how it can be utilized for the families that you serve and how you can get connected into it, refer, etc. And then we'll wrap up and so on and so forth. Lots of food this morning, so please help yourself at any time. So let's do our welcome and introductions. I'm Mindy Taylor, and I manage the Medical Home Portal, as most of you know, and I facilitate these meetings. We've got a couple folks connected to us through the USU sites this morning, so we'll say hi. Kelsey, we see you at the Blanding site. Good morning. Great to see you. And Wes, we see you at the Vernal site. Good morning. Great to see you guys. And we have a number of people on the meeting. So, Gabby?
So we have Erin Shoemaker. Erin, can you introduce yourself, please?
Hi, this is Erin Shoemaker. Can you hear me?
Yes.
Hi, Erin.
And then we have Gwen Anderson on the line. Gwen, can you unmute yourself and so Gwen has the microphone. So Gwen is working for Integrated Services.
Part of the
Eric team?
Yeah, so the Southeast Health Department, so Moab and Price.
right.
Kristen Samudio, can you introduce yourself, please? Still can't hear. Or you can write it in the chat box, and I can read it out loud. We have Linda Stephenson on GoToMeeting, and she's also working for Integrated Services in Richfield. Kristen says, hi, this is Kristen. Thanks for having me. Okay. We have Natalie Allen. Natalie, can you unmute yourself? Yeah.
Yeah, this is Natalie Allen, and I'm the nurse practitioner with Eric's group Integrated Services Program.
Perfect. Thank you. And then we have Neva on the phone. Neva, can you unmute yourself and introduce yourself? Or write it in the chat box.
I was muted. Hi, this is Neva from Shriners Hospitals for Children in Salt Lake.
Perfect. Thanks, Neva. Okay, so my name is Gabi Baragoshi, and I'm a QI specialist for UPIC and also helping Mindy a little bit on the medical.
And then we'll just go through the room and introduce ourselves if you don't mind. So, you want to go ahead?
Yeah. Jessica Stedman, Families as an Employment Specialist.
Welcome. Glad to have you.
Oh, I guess I'm Corrine Romero. I'm the Connector Service Care Manager at Primary Children's.
Good morning. Welcome.
Jan Boker, I'm a care manager.
I'm Dawn Bentley. I'm one of the QA specialists with UPIC, and Gabby and I are also the site coordinators for the Spark for Autism study, and I've noticed some of your patients have registered, so thank you for sharing that opportunity with your families.
I'm Cassie Crane. I'm a care coordinator at Wasatch Pediatrics South Point.
Greg Hawks with James Mason Centers for Recovery. We do the outreach.
Walt Torres, Department of Health, Integrated Services Program, and Care Coordinator.
Hey, Eric Christensen. I manage the Integrated Services Program with Department of Health.
Anna Reese, Southwest Children's Clinic, and I'm the practice manager.
Betters, I'm the care coordinator at Utah Valley Peds in Provo.
Tiffany Lambert, I'm care coordinator at Utah Valley Peds in Cherry Tree.
Jeanette Tingy, care coordinator at Utah Valley Pediatrics.
Pat Rowe, care manager for pediatric. I have to say it the same way. Pediatric care manager for Select Health Insurance. There we go.
Hi, I'm Heidi. I'm the nurse care manager at the Redwood Clinic for Pediatrics.
And I'm Gina Polameni, Utah Parent Center, Utah Family Voices.
I'm Kay Haynes with the Medical Home Portal Resources.
I'm Sylvia Barragon, Nurse Care Manager for the University Developmental Assessment Clinic.
I'm Angie Richens. I'm the Director of Case Management and Behavioral Health at Alpine Pediatrics.
Linnea Bauer. I'm the Services Support Manager for the Medical Home Portal.
All right, good morning, everyone. Okay, let's get on to our little bit of housekeeping. We just want to remind everyone that there are bathrooms in this building. Let's see, but there are, and the ones that are easiest for me to find are kind of just down this main hallway here. I'm just kind of tucked by the kitchen. That's the ones I know. They have a Blue Zone guest network here if you need Wi-Fi. And as always, we're being recorded. That's what this lovely red pulsing dot means. And that recording will disappear at 10 a.m. on the dot, and so will Chelsea and Wes. So we'll try and promptly right before that. Okay, so as we mentioned last month, we are trying to do a usability assessment of our website, particularly the area of the medical home portal that's focused on family information. And so we really could use some families of children with special health care needs to help us with that. The way they do it is through a little interview and a sorting assignment that takes maybe 30 minutes. And for that time, they will receive a $25 Amazon card. Via like a Skype session, if that works better for them. And so in order to try and help get this information to families that you think might be interested in participating, we have some little flyers that are right up here on the corner of the table by the sign-in sheet. So you can grab several of those, and if you don't mind, and maybe that'll help get some word out a little bit more. We're just coming up a little short. We need enough of a baseline that we get some good information about that. So we really appreciate your help. Okay, just wanted to let you know about some content updates. Last month I had 1 million. Lots had happened. It's a little quieter. People are on vacation. But we have recently updated our cystic fibrosis diagnosis module. It's a new module, but we had some experts review it, and they helped to improve the content with some clarity and some better information there. Module now, and updated some other content as well, and we just put an update out for our advocacy page. And as I read that, I thought to myself again, this is just great information. It's great information for anybody doing any kind of advocacy. So it's not even necessarily about parents and children. That is how it's written, and it's great stuff. But I would encourage you. I just, as I read through it before we hit the publish button, I went, oh, I just want to go change something now. So just let you know, it's a good page. I encourage you to read that. Okay, so this is your time. This is our brainstorming time, and so we hope that everyone, including the folks on GoToMeeting and the folks at our remote sites, will feel free to speak up and share. I do feel like everybody's a little tired this morning. I get that. I am right there with you. But if there's anything at all that you would like to ask for help with, if you would like to share, if you would like to complain, if you would like to update, that's exactly what this time is for. I think we really do all find it very valuable, even if you might think initially, oh, this isn't something that anyone would surprised. So, we love hearing updates on former cases that were mentioned. That's great. So this is your time, and if you're on GoToMeeting and you'd like to just chat in the chat box, that's a great way of. Also, feel free to unmute. Hop over to the Medical Home Portal, and I'll
Well, this isn't a particularly tough case, but I did want to bring up just a change in personnel in our office. Heather Carlson from our Ogden office has taken a position as the Early Intervention Director for Weber Morgan. I want to say school district, but the school district is no longer providing the early intervention. So those early intervention services have been brought back to the Utah Department of Health in the Baby Watch program through the Bureau of Children with Special Health Care Needs. So they've kind of taken that in-house. They were fortunate that they were able to hire a lot of the staff who was working for Weber Morgan school districts in the EI program, and so those folks are coming over as state employees. And it sounds like they had a relatively seamless transition from June 30th to July 1st, which is when the state fiscal year begins, to make that happen. Unfortunately, and fortunately for Heather, but unfortunately for us, we have lost an outstanding care coordinator, but she will do a fantastic job in that role of EI director because she knows every resource in 6 counties up north, so we're excited about that. However, if you still need to reach out to us, please, always our integrated services general phone number will get you to one of my remaining amazing care coordinators, which is the dead weight on the team. So anyway, if you need to call us, please still do that. Just know that Heather has moved on to, I don't want us to say greener pastures, but different pastures.
So, Eric, is this the sign of the future? Are school districts going to be farming off their...
I don't know that. I think part of it, too, was maybe a building issue. It was hard. Space was an issue. I don't know that the school district's heart was actually in it. And so I think it was really a pretty quick turnaround time. I think the school district kind of June-ish, May, kind of said, yeah, we don't think we need the contract. We've had some of the same EI providers, though, for years and years and years and years. What they're going to start going to, though, is a 5-year competition cycle for those early intervention providers. And that may shake up the waters just a little bit down the road as, people have to submit or respond to an RFP to determine if they would like to provide those early intervention services. And I've been told that they will not do all 13 programs or 15 programs, however many there are around the state on the same year, that it will alternate from various years how many of those are up for RFP. This was a really quick turnaround time, though, so I think the Department of Health was left with relatively few options, but taking it in-house, there's no time to put together an RFP.
And Eric, just from being on the council that kind of oversees, there's not that many that are actually a part of the school district. They're the competition programs, as Eric was saying, that will shake it up as they go, because most of them have been in existence for decades. So,
So it's not, interestingly, the school district, like with the exception of, I'm thinking of like Jordan Early Intervention, I mean, they're affiliated with the school district. Weber Morgan, but a lot of them are through private entities service. Or, I mean, Utah State University, they have services in Price up in Logan, and so they're more the type of providers that we're seeing out there rather than school districts taking this piece.
So I think what I'm hearing is it's always been a contracted job in the districts generally.
Yeah, so they were the ones who had the contract for Weber Morgan. Again, though, with shaking up the process every so often, every 5 years, an entity will have to basically bid on whether they're going to submit on the RFP to determine if they would like to participate any longer. But if there are better or more tantalizing bids, they could lose. So it's different than the way it's been done for the last 30 years. We've kind of had a captive group for that amount of time. That's good. That's also
I had an update. I heard yesterday Primary Children's just purchased some land in Lehigh. Building within the next few years more of another kind of behavioral health hospital. They have one in Taylorsville called Wasatch Canyons.
Right.
And so it's going to be similar to that. But I just found that out yesterday.
Is it on their same campus that they're doing the big main hospital?
I don't know. They did not tell. They didn't let us know kind of where that location is.
They didn't.
But they let us know that it was going to be in Lehigh. That they've purchased land.
Interesting.
So
Fantastic.
yeah, so that's kind of exciting from a behavioral health standpoint. So.
Thank you for
I just have a question that probably is going to go to these three people right here, but are they doing children's special health care needs clinics in Provo?
We have a very, very small presence there. Back in the day, we did a whole bunch of developmental type things. So, people with, who needed a second opinion on gross motor, or were concerned that a child might have, some sort of speech issue. Right now, though, 72% of the kids that are referred into Integrated Services Program / CSHCN clinics have been diagnosed with autism spectrum disorder or anticipating that they with that. So it's become almost more of a niche type of a clinic that we're getting the majority of children coming in for those services. We do get some behavioral piece, ADHD, ADD, positional defined disorder, things like that. But the majority of kids coming in are because someone suspects that the child has autism. So it's not kind of the big barn burner it used to be in the day where we had a cast of thousands and, we brought a big clinic in and some.
But you are doing testing.
We are doing
Is
some
it at
testing.
the health department in Provo?
No, it's at the Health Clinics of Utah, which is at the state building that is just down from the health department. So right on Center Street, just a little bit east of there.
Okay.
What's your wait time like?
It's a while. I have one psychologist. She does all my traveling clinics, and she does Salt Lake, Ogden, and Provo. So it's booked up. We're exploring some other options right now, and I hope to be able to talk about that in the next couple of months. But one psychologist, and as long as it takes to do an autism diagnosis and the huge reporting and all the records gathering and everything else, it's not quick.
Do you guys charge just a flat fee, or you go through insurance? Or?
We will be billing insurance. For the last year, we've just been using block grant monies to pay for it, so it's not been a cost back to the family. But we're working on getting credentialed and contracted and all the rest of it with some of the large insurance providers. So eventually, we'll accept. Historically, we've never said we won't take you because of the insurance that you have. We will usually insurance pays. If there's a balance, we apply a sliding fee scale, and some of our families made income such that there was no charge after what insurance paid. So we'll apply a sliding fee scale. We will bill insurance where possible.
But you're
For
able
families,
to balance bill.
Let me put it this way, and I never said this, but we do not have a collections department at the Department of Health. So I'm just saying, if you owe me $2, chances of me sending Uncle Gino out after you to get those $2 probably isn't going to happen. But we will balance bill. We just won't be incredibly aggressive with it because we just don't have the staff to make it happen.
Right.
So it's a kinder, gentler way to get it done. But again, it's a very long wait. And so we refer folks up to UDAC a lot. We refer folks to other providers who can do that close to home. However, if you're in Blanding or you're in Rice or somewhere like that, you don't have lots and lots of options for that.
So what's the turnaround from if they have testing done, they meet with somebody, have the block of testing done, that a parent would hear back and this is
It takes a little bit of time because it's a couple of visits. We do a diagnostic evaluation. There's then the testing piece, the report writing, and the visit. It can take 2-3 months sometimes to get through that. We're trying to work it now, though. My psychologist was brand new out of being licensed. And with a year under her belt, we're really trying to get to the point where we can knock it out in a month. But we have a little bit of a backlog that we're trying to catch up on.
So a parent that met with somebody in April, should they have been...
July-ish is probably about on track.
Okay. And if they get testing done through you, are they waiving their rights to have it done through the school district?
That's a different usually, I'll be honest with you, my wife is a principal. The school district tries to do the least amount possible where they have to. A lot of times if you're bringing in a medical diagnosis of autism, they'll accept that and use that for your educational placement.
If it's done by a psychologist, they consider that the gold standard and they'll accept that. It's my understanding the school districts aren't doing like an ADI and ADOS. I mean, they're expensive tests.
Well, let me tell you, I thought the same thing, but one of the teachers that works for my wife, her daughter was diagnosed through the school district with a psychologist who did an ADOS. That shocked me.
It really varies, though. Oh, my goodness. You can get a wonderful evaluation through the educational system, and you can get something that I could have done.
Yeah.
I mean, it varies so much that it's almost not trustworthy.
Well, it shocked me that there was this in-depth piece done by a psychologist, because usually what I found is it's been path of least resistance to get you that educational placement in the classroom. So it surprised me. I don't think that's the norm. It will be interesting to see with
It is in Utah County.
with some of the places, some of the school districts that have implemented more behavioral health in the schools and some additional staff, if those types of services will increase. But, it's time consuming. And when a psychologist is responsible for dozens and dozens of kids at a school, you can see where the time.
Somebody's going to cash pay for you, like they don't have insurance. What do you charge?
So we would be on a sliding fee scale. And I have to be honest with you, it's going to be based on the number of hours that the psychologist spends, doing the piece. So, I really want to say, just historically, about $1,500 was like the charge to do all of it. And then with the sliding fee scale, we look at families' gross income, gross monthly income, and then we allow medical expenses, other types of, so insurance premiums. If you owe a bill to Primary Children's Hospital and you're paying $100 a month on that one, whole bunch of different types of deductions that we pull off of that to bring that into alignment. Our sliding fee scale is based off of federal poverty guidelines. It's published in the National Register every January-ish. And so we're running off of 2019 numbers that's published in January. And our families, based on family size and monthly income, after we adjust that down where they fall into that, we have a sliding fee scale established. But for right now, till we're all credentialed, we're not billing stuff out. So
interesting. Okay.
But I'm just saying caution there, because within the next few months we probably could have all that in place. So
right.
So then just one clarification too about where the child gets the diagnosis. The schools, if they have the capacity to do it, it really is for their placement and their instruction, specialized instruction.
Not for state services.
So families kind of fall into that trap, and then they'll go to apply for things such as DSPD. They really do need a medical diagnosis outside the school. So families kind of get caught in that, and both are needed for all programs. But if there is a medical one, then the school will take that into account because a lot of families that have been diagnosed with autism, they won't automatically go into the school and be lumped in that autism category. They'll look at what their needs are educationally, and it may be under specified learning disabilities, which also throws families off. And again, for the education system, they're basically looking at what type of specialized instruction that the child is going to need to meet what the law says for IDEA.
Every child is different. For example, this young lady that got the diagnosis through the school holds it together pretty well at school. She falls apart at home, but she holds it together, and learning-wise, she does great. So, IEP-wise, there's just not a heck of a lot there that they really need.
Very high functioning.
Super high functioning. It's just very interesting and varied.
Can I insert?
Please.
I'm Lana Stohl, by the way. I just have a question for Eric, maybe, or whoever else. Do you guys make private referrals? I know of a program. I have no financial interest in this program at all, but I don't know how many of you are familiar with Matt's Place. It's in Davis County. The owner of that has a child with autism. She's an APRN. Has psychologists and a day treatment. They have a full range of services, but they do the testing as well for autism. I'm not aware of what they charge specifically, but this is a labor of love for them, she and her husband, because they have a child.
When we get a referral in for a family and they're seeking services, we, if they're in one of our rural areas, we really try to kind of keep them there, but we do say there is a wait. So if you're able to come to Salt Lake or wherever, and we'll give folks a whole laundry list of different places. We don't advocate one place over another. We'll just kind of say geographically, these folks are closer to you, but you'll need to call around and find out what it's going to be cost-wise or whether it will work for you and what the wait even is. And if folks have trouble navigating that, our care coordinators will help figure some of that stuff out. But we do make private referrals, and sometimes I say get on as many lists as possible if you have the ability to do it. Whoever can get you in the quickest, and you can afford it, snatch it up.
Yeah. Well, and Matt's place is actually getting ready. They purchased the land and have the building stuff in. They're opening a facility in St. George as well. So, and at some point, maybe in the Utah or in Salt Lake, Utah County area, but they definitely are. Which I think, for us, will be huge. Some of our kids. So.
Thank you. That's great. Yeah.
The Matt's Place record in the medical home portal, they have a MD in psychiatry, so they have some auxiliary staff. Keep growing.
Yes,
in
they
terms
keep
of their
growing. They've
professional.
outgrown their facility in Davis County by. So.
I feel like we used to mention Matt's Place a lot in these meetings. We've done it for a while. Definitely.
And I think last time I visited them at Matt's Place, they were relatively new in that building now, so that's been a couple of years at least.
We'll follow up with the resources of the month and maybe put in
Just an update on Greg's update. Dr. Mickelson, Travis Mickelson, said that he thinks that the campus will be the same.
Oh, like a
they'll be on the same campus.
Just
So
an
the mental
interim
health,
building kind of thing.
probably, and that he said years away.
They said probably 2023 maybe.
Yeah.
Oh, I thought you said 20 or 23 years.
I don't know. Yeah, 2023.
This is like beginning stages.
Yeah, I had heard about the medical, but I hadn't heard about the mental, so that's cool. There's a real need.
And fortunately or unfortunately,
Sooner than later.
That's true.
helpful. Okay, well that was a little different than some of our normal brainstorming sessions. That was really good stuff. So thank you everyone. And I think we need to actually back to our regular agenda and turn it over to Lana Stohl. So welcome. Got your PowerPoint right here, and I wanted to let you know that we are also sharing this meeting with a number of people on the web. And the way the technical aspects of this room work with that GoToMeeting connection is that we can't use the presenter mode on here. They are not able to see it on their screen. I apologize for that.
Okay.
But everyone's used to it, so please don't worry about that. The other thing I'm going to ask you, if you don't mind, is to use this little guy, and you can click. Yeah, I don't know, right?
Yeah.
Oftentimes, I will just I'll just hold it. So this helps our people again on GoToMeeting to hear you. And the screen light you see by the grid up there, these two panels are the mics for the room. So if you want to stand closer to that, that helps too. But if you have the handheld mic, that's really good.
So I'm going to try to do this.
Okay.
Let's get this on. There. Hopefully I'm not going to laugh people out here. Okay, can folks, does that work? And I guess if I'm understanding, I can't put it in slideshow.
That's right. I'm afraid not. And I'm happy to advance slides for you if you want.
Okay.
I'll just be right here taking some notes, and I can, if you want to just look at me, I can do it. If you want to wander, or you can.
I will try to do this.
Okay.
Then we'll see. I'm usually walking all over the place. Good morning, everyone. It is a real pleasure for me to be here. I really appreciate Gina asking me to come and talk about system of care. And I could talk about system of care all day, but My understanding is I have about 45 minutes. Is that correct? 30 minutes?
45 is great.
45 is great. Okay, so, and I welcome questions as we go along as well. And just a little bit about myself. I'm the Deputy Director of the Department of Human Services, but I'm also the department's System of Care Director. And I have been in the behavioral health field for over 40 years. And so I have had a lot of experiences over that period of time. In case you can't hear it, I am not a Utah native. I grew up in the hills of eastern Kentucky. And so you'll probably hear some of that come across as I talk this morning. And let's see what else you need to know about me. That's, I guess, pretty much a great introduction. So let's talk about system of care. The first question, I think I have a relative in here. The lady whose last name is Lambert, that was my maiden name. So,
and it's my husband's adopted name, so I
okay.
have no idea.
Well, maybe we're connected somewhere along the way. But I look back at you and I saw that and it's like, yes, maybe some distant relative. But anyway, so let's talk about system of care. So how many of you know about system of care? Okay, just a couple. That's probably good for me because as we move forward, hopefully I can share some stuff with you. The department, and I'll share a little bit more of the history a little bit later, but as all of you know, and I could hear parts of it in the discussion that we just had, as you know, our systems are often very fragmented. And we don't do professionally, our various systems do not do a very good job of coordinating. And not only is that true across agencies, but it's true within agencies. And I'll use our agency as an example, the Department of Human Services. When I first started with the Department of Human Services, you would have thought that every single one of our entities were their own separate kingdoms or silos. There was really no integration between those systems at all. And our four major child-serving agencies are Child Welfare, DCFS, Juvenile Justice, Substance Abuse and Mental Health, and the Division of Services for People with Disabilities. And for years and years, those operated almost totally independently of each other. And we were really focused on what door you entered as opposed to what the underlying needs were. And we were very inconsistent in terms of responding to crises that families may have. And our systems tend to have inconsistent responses. It depends on, a lot of times it depends on the person that you come in contact with in terms of the services and resources you may have access to. Inconsistent planning efforts, you all know this. Parents and families not involved in the decision-making process or planning process for their kids. Really that inconsistent matches services to needs. And so one of our mantras at this point is the right amount of service at the right time and the right in the right setting. And then our system, I think none of us would say, and it was again reflected in the discussion that we just had, none of our systems, we lack the services and supports that many of our children and families need. And so in an effort to address some of those kinds of things, one of the things that shortly after I joined the department's leadership, we talked about a national evidence-based program called System of Care. And the concepts around System of Care is that it's organized into a coordinated network, that it builds meaningful partnerships with families and youth. And that is a difficult one, I think, for many agencies to pull off. It's one that the department is becoming more and more committed to, and something that I really value about the work that we're trying to do. It addresses the cultural and linguistic competencies of families. So it's basically, we start where families are, and it really, our goal is to help children and youth function better at home, in school, and in their community. So it's really all about developing a framework of community-based services and supports for children. And one of the things that our department has also historically been challenged with is a lot of children getting referred into either JGS or DCFS custody for services. And that is one of the key critical points at this point that we're trying to focus on. So if we look at kind of where we were to where we're trying to go at this point, we're trying to move from that fragmented service delivery system to a coordinated service delivery system, from categorical programs and funding to braided and blended services and programs. And I don't know, I'm sure you all are very aware of how difficult that second one is. I mean, I fight battles every day, even within our own department, to get our agency partners within the department to understand that it is, in essence, it's the department's money, and these are all of our children. It's not like, okay, this one gets shipped to DSPD and this one should go to child welfare, because most of the children we serve, and I'm sure most of the children you serve, are not, they don't have one really specific issue. They are often kids with very complex needs. So limited services. We have system of care available all across the state, and one of our greatest challenges is the lack of a comprehensive array of services. And trying to move our system from being focused on residential services to that more community-based service system is really challenging at this point, but and particularly in the rural areas of the state. We're often very reactive and crisis-oriented instead of trying to focus on getting upstream so that we can prevent those crises from ever happening. And I don't have time today, but I could tell you some horror stories about children that have been in our system for years and where we are crisis mode all the time. And part of it is because I think we took those children out of their communities in that normalized setting many years ago. And then we focus on the deep end. I've talked about a little bit about that in terms of our system was built on residential care. And a little bit, some places in the state, and let me back up a second. I'm not being critical. There are glowing examples all across the state of successful programs, but I'm talking as a system overall about what the challenges are. It was these, again, we got children referred all the time for what we called dependency, and it was based on trying to get a child access to specific types of services. And it is really difficult for me to think about a system that will remove children from families simply to get them access to the appropriate level of services. And so that's one of the things that we're focusing on. We're trying to balance that centralized authority with more community-based ownership. System of Care has regional advisory committees or councils all across the state, and I'm headed to Moab when I leave here for one of our regional advisory committees in Moab today. And then we are trying to move away from fostering dependency to building on strengths and resiliency instead. So that's the kind of the characteristics of our system reform. And so what is the overall goal of system of care? And I've talked about it. We want kids to live in their families. We want kids to be in the least restrictive school setting possible and be in their community schools. And we also want kids successfully thriving in the community. I'm getting a little bit of feedback, so I'm trying to... Is anybody hearing the feedback but me? If nobody's hearing it but me, I'm good. Okay. So let's talk just a little bit more about, and you guys know a lot of this, but what's at the core of system of care are a set of values. And those values are family driven. And I can't emphasize how important that is. Oftentimes as professionals, we come up with a treatment plan and then we tell parents what we think they should do, instead of asking parents what they need and want from us. I've talked about culturally competent, youth guided. We have a consultant from New Jersey who's built a wonderful system of care, helped build a system of care there, and they actually have DSPD as part of their system of care, their whole system of care framework. But she keeps saying to me, ask the child what they want, what would help them. And that's obviously more appropriate as children get older, but we have all these discussions about kids and what should happen to them without actually asking them, what do you want? And there's a great video by John Brandenburg about a little kid in Alaska who went through the entire system, and what he kept telling everybody is, I want to go home and live with my mom. And he was placed in youth corrections facilities, residential facilities, out of the state, all sorts of things. Where did he end up? Back home with his mom, which is where he wanted to be from the very beginning. And how could they have put services and supports in place to make that happen? Community-based, trauma-informed. I know that there is a lot of discussion at this point around trauma, and I believe that a lot of children get diagnosed with a variety of things when, in fact, they are victims of trauma, and how do we not keep re-traumatizing children and families over and over again. And we're very clear that removing children from their homes creates just another set of trauma or another traumatic event for them and also for their families. And so we want to be strength-based. It's so easy with some of our families to really look at the negatives. And a lot of our families are known in the communities. And you say their names and everybody starts rolling their eyes, or it's this family again. But I don't believe that there is a single family that does not have strengths that we can build upon in order to move things forward. And also the biggest and probably the most important is individualized. And I'll use an example from our system, and I hope none of my system fit folks that may be listening will think, oh, she's not doing a very good job of defending it. But in our system, we tend to have a recipe, if you will, for children. We're going to give everybody individual therapy. We're going to give everybody family therapy. So we've got this set of boxes, if you will, that we check off. And in most cases, and I'm a therapist, and I did therapy for years, but unless a child or a family is ready for therapy, that may not be the most effective thing. And in most cases, they will let you know when they're ready. So it's like forcing a child to go sit in therapy for years and years and years. Those resources could probably be much better spent in other ways. So I think it's problematic that oftentimes we have this checklist of things that are automatically recommended to every child and family. And I've seen it in court orders for children that have been ordered into DCFS. They throw the whole kitchen sink at a family instead of focusing on what is the one most important thing that we can do with this child and family to get them back home. So, and I'm sure I'm preaching to the choir here. Anyway, so I think about system of care. Some people think about system of care as a program. I think about system of care as an overarching set of values. And what our department is trying to do is to infuse those values into everything that we do. What the service that system of care actually provides to children and families is high fidelity wraparound. And that is, you can see the definition here, a defined evidence-based planning process that really results in a unique set of services and natural supports. And I can't emphasize how important those natural supports are, that are absolutely individualized for the child and the family. And we set outcome goals that are very short-term and very focused. So we're reviewing our plan instead of saying the child is going to build self-esteem. As a therapist, I saw that on treatment plans for years and years and years. If that's the goal, what are the measurable, small, incremental steps and what's the evidence that you're making progress there? And it's that theory of change that's strength-based. It's about increasing engagement. It's about self-efficacy, social support, and maintaining positive outcomes. We want children to exit system of care, or our system of care program and our department able to solve their own problems, as opposed to them being dependent on us as a system for years and years and years to come. And as you guys may know, the outcomes for children that are raised in a state system are dismal. How many of you seen that new movie? I think it's called Perfect Family, or it's
Instant Family?
Instant Family. Instant Family. And there is a scene in that movie where a girl gets up and tells this group of prospective foster parents that children exiting foster care, the vast majority, I think it's like 80%, will be homeless, in prison, drug addicted, after they leave our system. And is that the outcomes that we want to achieve? It's not the outcomes I want to achieve. It's not the legacy I want to leave in our system. So what does it really mean to be family driven? And we talk about this all the time. A lot of times we say, well, if we ask the family's opinion, that's being family driven. And for us, family driven means they are the primary decision maker. They are responsible for the care of their own children, and if we give them adequate resources and supports, we can accomplish that. And that we have those, and that they help us. Gina serves on our state level integrated service delivery committee, and the goal of that committee is to make sure at that highest policy making level we have family voice and involvement at that. And all of this includes, determining what types of services, choosing the culturally and linguistic components, what do they need, setting those goals, designing and implementing and evaluating the programs, monitoring the outcomes. We're working right now at the department level to try to make sure that we have family voice in the monitoring process of all of our programs and services for children and families, and that they partner with us in funding decisions. So that's the family-driven piece. And the youth voice piece, and I talked a little bit about this, it really means that what we want to do is value what youth have to tell us. How many of you have been on panels where kids have talked about their experiences in all of our systems? Anybody had that experience of listening to a panel of kids after they've come out of our system? it is gut-wrenching to hear what they experienced from us and what we didn't give them the opportunity to say to us as a system. So having that voice is really important. So those are some of the core principles and of system of care and how we view what we're trying to do with our system of care program. The department has been involved with system of care activities for a lot of years, going back to 1989. How many of you were around when FACT was Gina's? Yeah, a little bit. But FACT was system of care, and it actually was implemented at one point statewide. There was a battle legislatively over funding, and all the money was pulled, and it went away. What has happened historically is we would get a system of care grant for a particular community, and once that grant money went away, there was no sustainability, and the program went away. And one of the decisions that we made early on with the last system of care grant we got was to make it statewide. We had to have department leadership involved. And fortunately, we got that, and we have transitioned off of our federal grant, and the department is sustaining system of care with its own resources, which is remarkable. I mean, I will be the first to say I wasn't sure we could make that happen, but it is. So also, and a lot of folks are not aware of this, sometimes I have to remind our own legislative folks, we were able to have system of care put into the department statute. Basically says we have to function from a system of care perspective. And that helps us legislatively in terms of resources. But we've had some really key sponsors for system of care, believers. And the first one was Dean Sonpei, who was a part of the Executive Appropriations Committee when he was here in the state. Representative Edwards was a huge proponent of system of care, and she left the legislature, but we have real champions in the legislature, and it's a part of the department statute. So it's not optional. System of care is not going anywhere. If you hear anybody saying, well, system of care is going to go away, it's not, because it's statutorily a requirement for our department. So, and as I talked a little bit about, we're doing an integrated service delivery model. We want a department-wide approach. We want to focus on those needs and not doors. And we've used the system of care grant as a springboard to really reshape the department. And we're using our system of care teams out in the regions to inform a broader array of services and decision-making processes that will hopefully, over time, it took New Jersey about 20 years to get to kind of where they really wanted to go. And we've been at this for 4.5. I keep trying to tell people who want it changed instantly, this is a process, and it's not going to it's not going to be an easy process. So I'm trying to figure out where I'm at in terms of the slides here. So there are really two independent elements of system of care, and that really is the statewide efforts, but also what we're doing at the local level. Those regional advisory councils, we're trying to give them access and ownership of resources and help us develop service delivery and really identify what's unique to their communities. And then all of that then should come back and inform what we do at the state level in terms of policy and process and resource changes. I think I've talked about most of this. I want to make sure that we have some time to really identify. One of the things I do want to highlight in here, workforce development is a huge issue, and I'm sure it is probably issues in your systems as well, because we are having increasing difficulty finding staff who will work for the state for what we are able to pay. And our contractor who does all of our family peer support and youth peer support, allies, is also struggling to be able to pay staff a living wage. And so that is really a challenge for us. So this is just a graphic. We have the state commitment, we want local ownership, and we're also working with our tribal partners around the state as well. And then what we're doing at the state level also is, and this was really first frustrating, when we first started System of Care, we would have a department contract for a particular service that a System of Care family needed. But because it was division specific, we couldn't get the service. And that I went nuts, frankly. It's like, on our contracts with various providers or entities, it would say the Department of Human Services, the Division of Services for People with Disabilities. And our attorneys would be saying, because it says it's for the Division of Services for People with Disabilities, System of Care could not access that particular service for our children and families. Sounds pretty nuts, doesn't it? So we are doing state-level contracts now for all of our services. We are also developing a much greater emphasis on data and monitoring. We're doing the integrated work. I'm going to talk a little bit, if I have time, about mobile crisis stabilization and mobile response. How many of you are here in the Salt Lake area? How many of you Davis County? Davis and north of Davis County? Utah County? Okay. Anybody from the St. George, the western area? Okay. Our stabilization and mobile response right now is north of Salt Lake and in the southwest area. We hope to be able to make an announcement soon about that being available in Summit, Tooele, and Salt Lake County. But our efforts are going to be statewide, and I'll give you a little bit of information about that. But anyway, so
the two folks that you can kind of see looking at that back screen are both in the southeast part of the state. So,
southeast?
Yeah.
We need southwest. The southeast is we desperately need stabilization and mobile response over there. So we're trying.
So we've got Vernal area with Wes and Blanding with Kelsey.
Oh, okay. So, but that is going to be huge, and that's our upstream piece. And with our contracts, one of the things we're trying to do is quit focusing on the minutia and look at what we want in terms of outcomes. Our contracts had grown to like 70 pages or something like that. And it's like, let's focus on what the outcomes we want to achieve for children instead of all of these, little, you have to do this and this and this and this. So let's talk more specifically about what we're doing in the local areas. And I'm trying to, okay, so I talked about the high-fidelity wraparound teams. We have high-fidelity wraparound teams all across the state. And they do that intensive in-home work with children and families. The teams are composed of a care manager and a family peer support, and in some cases a youth peer support. I would love to have a youth peer support with all of our teams at this point. That's a goal. That's not a reality yet. We've got a youth peer support in Salt Lake County, but we need that youth peer support as in our system as well. And again, they spend their time in in the homes of the children and families that we serve. We serve families with absolutely the most complex needs. And many of these kids are sitting on the department's doorstep with either an order pending for them to come into custody, or, I mean, we're that close to having children removed from their families. And I could tell you tons of stories about kids and families that we have been able to keep out of custody. One of the most impactful for me was one of our very first families when System of Care rolled out its first team. We had a family of 9 children. DCFS already had the petition, whatever they do. I mean, they were getting ready to file the petition in court. One of the children had severe disabilities and was basically aggressive and beating up a lot of the other children and her parents. We were able to work with all across the systems, BSPD, child welfare, all of our various partners. We were able to place that oldest child in a DSPD service that was very appropriate. I mean, it was an appropriate placement for that young woman, and she's done very, very well in that setting because her needs were being met. And there's obviously still a strong connection to the family. We did not have to remove a single other one of those children. And so if System of Care did nothing else in the whole time it's been in existence, keeping those 8 children out of custody, from my perspective, was worth every dime of it. Because I think we changed the trajectory of their lives and their mothers' lives. And I mean, they've struggled, and their father died in the middle of all of this, but it was just an incredible success story. And I mean, we have those stories. I could tell you story after story in every single one of our regions. And it really is about getting the right services in and helping the family identify the natural supports in their own communities. It's been remarkable how effective that has been. We had one little girl that all the neighbors were complaining about mom not supervising this little girl. She was incredibly difficult. And when the System of Care team, with mom's help, talked with the neighbors and explained some of the circumstances, and that whole neighborhood joined that mom in caring for that child. So if anybody saw her, instead of calling the police or, saying she's a bad mother, they knew what mom was dealing with, and they went out and helped mom with that, take care of that particular need. So that community wrapped themselves around that child. We had a case also where we had an adopted child that on his 18th birthday, his adoptive parents dropped him off at the homeless shelter. And he had significant challenges. Working with a System of Care, we identified an individual that was willing to take that young man in and provide him a home. And he is going to college. He is flourishing. But he was ready to be homeless, basically, and victimized for the rest of his life. So those are some, but anyway, we're really, our focus is to help prepare children for life. One of the things that I say, I don't want to raise the next generation of adult chronically mentally ill individuals. I don't want to raise the next generation of prison population. I don't want to raise the next generation of families who are in our child welfare system. We want kids to transition successfully into life. And so I'm sorry, as you can tell, I get pretty passionate about what we do. I mean, it makes the difference, such a difference. And so this is just a graphic on the phases of Wraparound. And you can, these slides are available for everybody, right? Okay. And then this is a graphic of our regional staff. We have a regional coordinator who manages teams in those regions. Like in the Eastern region, we have a team in Vernal, we have a team in Moab, we have a team in Price. And so there's a team spread all across that region, and the regional coordinator supervises. Can you imagine supervising from Box Elder or Daggett County to San Juan County? That's her scope, but she's fabulous. But those are what our region teams look like. Again, this is just another graphic. This is our goal: is one team, one plan. I hope you realize how difficult in a department like ours that is to achieve, because everybody thinks they have to do everything. A lot of people think they have to do things the way it's always been done, and so one team, one plan. And child welfare may need a plan for court and their stuff, but if we integrate all of those plans and we go into court as a team, we're much more successful with judges than if we go into court separately. And then, so what children and families do we take? So we take kids that are younger than 22, and I shouldn't probably call them kids, children and youth. Our primary criteria, are they a recipient or are they at risk of receiving services from two or more of the Utah Department of Human Services agencies? And so you can see that child welfare, juvenile justice, services for people with disabilities, mental health, substance use, and or the courts. So that's the kind of tip of the iceberg, if you will. If you think about children and their needs, there's this core group of children that are at the apex of the triangle that utilize most of the resources. There's the fewest number of kids, but they utilize most of the resources. So that's really our primary focus. I can tell you from experience, and this really surprised me, the children that we often accept into system of care, many of them have not been diagnosed. This was how I was interested in the discussion we had just a little bit earlier. They have not been diagnosed with autism, but it's really clear they're on the spectrum. One of the most requested and successful services that we're able to give to families is behavior supports. They need help developing skills to manage the child's behavior in their own homes. We also see a large number of children who have been fetally in utero exposed to drugs and alcohol, and so they do not have the executive functioning skills. To folks say, because they kind of quote unquote look normal, people expect that they are able to do things behaviorally that they simply do not have the skills to do. So that really surprised me. We need respite desperately for these families, and so are they at risk of being placed in custody? Does it prevent, if they're in a residential placement, are those behaviors and concerns self-harm, preventing them from returning home, or are they at risk of being removed from the home? Are they involved in juvenile competency? Do you guys know what juvenile competency is? Okay. Juvenile competency, the state passed a statute several years ago. I was a strong advocate of the statute that basically said kids who did not have the capacity to understand the judicial process and what they were being charged with could not be charged. So kids with disabilities were ending up in the juvenile justice system without the capacity to understand and participate in their own defense. In most cases, they didn't have a defense attorney. And so there's now a juvenile competency process where a defense attorney or prosecuting attorney can raise that issue Does this child have the capacity to actually understand and participate in their own defense? Or can they gain those skills? And what was happening was those kids would be found not competent to proceed to trial, but not able to attain competency, and they were dropped. It's like, and some of these children had incredibly complex and dangerous behaviors, and so we included that juvenile competency process. And then the department has a high-level staffing process with some incredible cases, and those kids are also kids that we focus on. So, and I'm just about done, I promise. So it's not limited to, so our referrals are not limited to state custody. Families have to agree. We do not mandate participation in system of care. If you force it, it will not be successful. So families choose to be a part of it, and that's part of that voice and choice. I mean,
But part of the family, the parents or the child that has the behavioral problem?
It's the children, but as I said earlier, most of our families are very complex families. Families that, parents are having difficulty, the children are having difficulty, so it's a variety of problems and issues. It's not there. There's not just one single thing. I talked about that, and our local interagency councils reviews and helps us select. They're not the final say, so we make decisions on some referrals we get directly. We're getting a lot of referrals from the school systems. We get a lot of referrals from DCFS and juvenile justice. We are seeing a lot of children on that, as I said, on the autism spectrum. So a lot of kids with DSPD related issues. But it is not. And this is just kind of the triage of how the referral process works. And so any of you could submit a referral. Our regional coordinator would screen it based on wherever the child and family lives. They would then get back to you and say yes. And we have what's it called? We have a triage process where we say, okay, if these 5 things are happening, this is like a number 1. We're going to take this child and family next. And then this is maybe a number 4. And when we have a vacancy, we can take those. And we're actually, one of the reasons stabilization and mobile response is so important is because that's going to be the bridge between no services and moving into that system of care arena, because we will be able to provide 8 weeks of intensive in-home stabilization. So that's what's happening in the Southwest region and everything north of Davis County. Families have access to 8 weeks of intensive in-home services that they don't pay for. And then let's see, 2 more slides here, and I'm done. This is our regions. We tried to mirror them around the DCFS regions, but we also did not want to break up local mental health authorities because they participate on our teams as well. And so we aligned them with local authorities so we didn't have to split. They didn't have to split across 2 regions. And we are everywhere in the state. And we've had kids from on the reservation, to Box Elder in Daggett County, St. George, so we're getting kids everywhere. And this is just our governance structure. So we have those local teams, those regions, local leadership. I'm going to the advisory council in Moab today, and then that feeds up to our integrated service delivery team at the state level. And then there's an executive directors council, which is director of health, workforce services, and human services that meet regularly and deal with those issues that cross those various agencies. And so that is a little bit about system of care. And questions, things that are confusing, yes.
Go ahead.
Jane.
I am kind of curious as to where we fit in. So I'm a care manager in a pediatric office. I believe one of my clients is in the system of care. I've had absolutely no communication. So I don't know what's done and what I need to do, and Mom's not a good communicator.
Oh, okay.
So how can we be a partnership?
Okay. Well, what region are you in?
That one would be Salt Lake.
Oh, Salt Lake. I can send this whole group, if you have a mailing list, I can send you the regional coordinators for every region across the state. So if you have a question or concern, raise that. We, with the family's permission, and we want to involve as many people on the team. I mean, some of our teams are like 30 people. We want to involve everybody who's a part of that family. But again, the family gets to decide who they want on that team. And they may be perfectly glad to have you, Jan, on the team. Sometimes maybe, particularly in medical practices, they think, these folks don't have time. But I'll send this group, our regional coordinators, contact information so that you can contact our regional coordinators if you have questions.
I think it sounds like a wonderful program. I think sharing is knowledge. So if I'm seeing this child that needs X, Y, Z, or what's happening, how you see it through the hospital or you see it through coming in, I want to make sure that his needs are being addressed also, and the family's needs. But if you don't know what's really happening, there could be a gap that way. So I think communication from your teams to the individual medical office is very important.
Well, and you've made an excellent point. I'm not sure I would hope that our team would know of your involvement, but if they don't, I would hope that all of you would feel comfortable with picking up the phone and calling that regional coordinator, because they know about every single case that's going on in their region. So don't hesitate to do that, and they can have a discussion with the family and say, Jan and her team may be able to help us with services and resources that we've not thought about. Can we include them as part of the team? And you guys have access. We get lots and lots of referrals from hospitals, from doctors, we have a pediatrician actually on our advisory committee. So we want to be involved. And many of our children also have complex medical needs as well as behavioral needs or emotional needs as well. So there is a logical connection.
So along the lines, piggybacking off what Jan said, historically, issues such as HIPAA, FERPA, 42 CFR, and all of those restrictions there have kind of precluded some of us from trying to work together, even to our best efforts. We've jokingly talked about coordinating the care coordinators sometimes is like herding cats, because you have all these well-intentioned people on the medical side, on the behavioral health side, really wanting to help the family, but I think a lot of times we're duplicating efforts, and nobody has that kind of cash flow anymore to be able to duplicate, efforts for families. We found even just within medical, sometimes we go in all well-intentioned and both guns blazing, and we undermine what somebody's been working on for months when we hop in with the family. So what's really a tricky part is, how do we create a single plan of care amongst human services, health, all of these entities involved, so that we're all contributing to benefit this family, work for the children in question, and how do we make that work? And so I don't have an easy answer for that. We had a grant, a D70 grant from HRSA that we spent 3 years on, that we were really trying to get to maybe a common platform where we could share information amongst various service providers. I'm going to tell you, 3 years later, I don't know that I feel like we're any further ahead on that than we were starting at those 3 years.
Well, what I can tell you with our system of care cases, and we're working to implement this basically at a department level. But if you're a part of a system of care team, you have access to everything, all the information. I mean, like you guys, it took a long time working with various attorneys, but we have a release that covers the whole team and allows for the sharing of information across that whole team. So we can give the medical provider what information we have, and the parent signs this. It basically, we can't do a team unless the family is willing to have us be able to share that information. And they sign a release of information saying, I understand that becoming a part of the system of care means that the whole team is going to be able to, know what each other is doing, that we don't have to get 20 different releases of information to be able to share across that team. And, sometimes, obviously, if there's, we would not share really like therapy notes or some, those kind, but in terms of coordinating care, absolutely. And the family gives that permission from the very start. So we can do that. Yes. Oh, I'm sorry. You were first. I can't see your name.
It's Corrine. So I, just to make it brief, I had a little guy that I was dealing with who had multiple problems. He passed away. His family had been homeless. We helped him get a home. DCSF was involved. They still are involved. But during the time, right before he died, I went on a home visit and the curtains were all slashed. And I'm like, what happened to your curtains? And they're like, well, their oldest son got mad at the mom, came after her with a knife, cut the curtains. The police came, took him away. And we were having a meeting with DCSF that day. Like a whole team of people were there. But DCSF is separate from this, right?
DCFS, if
or
DCFS,
part of this, but not.
Well, if DCFS, we're not part of every DCFS case, but if DCFS is a part of our case, then they are part of that team.
So they would need a separate referral to this. I guess my point is
that there does have to be a separate referral. Now, if DCFS can make that referral directly to us as well.
So maybe they have, I don't know, but because this little guy died, so I'm not involved with the family, but I got a text last night from the private duty nurse that had been caring for that guy that she's getting texts from the kids in the family that the son is still coming, is very violent. The mom's called the cops. They take him for a day. Then he's right back and they don't feel safe. So would this be something?
Yes.
Okay. I'm like, where else do we go? She's like, I don't know what else to do.
Is it Salt Lake?
Yes.
Okay. Again, I'm going to send you the regional coordinator's contact information, and they'll be able to help
I
you
don't
on
know
that
if
case.
they're already involved or not because I've been away from it for a little bit, but they need something more, something that's going to die
and you're
in the
right.
house.
And juvenile justice is also doing some new services, more of that front end stuff as well. And they're going to have some wraparound teams as well. So we're trying to expand the resources as we go. But if you'll call the region, if you have a case like that. Where children's lives basically are in danger.
I told her, I said, they wanted to come to her house. They're like, will you come and get us? And I said, you can't do that, but call DCSF, call the police. And the girl responded, we have, and they don't do anything.
And sometimes the police get to the point where it's like, we're not.
Well, they take him away and he's right back the next day or 72 hours later or whatever. So.
I would encourage the utilization of the Youth Services Center here in Salt Lake. In that case, if he has not already been there, there's going to be a Youth Services Center in regions all around the state, and they're going to be kind of also that drop-off point as well for police that will help them integrate more with us. We do not want the kids to become, we are not trying to create a prison pipeline by having police involved. Now, if we have, when we get, I'm going to pass out three things here.
I'm just going to interrupt really quick and say to Wes and Kelsey, we're probably going to pop off. So thanks, guys, and goodbye. We'll send out a summary of the meeting so you guys will have everything that's said after you aren't here anymore.
Thank you, guys, for being here. And so, there's a card about what system of care is that you can give families, a couple of things about our requirements, and then this is a card about our stabilization and mobile response. And there's a telephone number. It's one.
Your meeting has ended.